Today, we're breaking down a really high-stakes situation. What happens during a medical emergency that unfolds not in a hospital, but right in a patient's home? We're going to look at the anatomy of a coordinated, life-saving response.
So let's dive into the world of advanced home healthcare. We're looking at a scenario where a specialized team has to act with absolute precision when a patient suddenly starts struggling to breathe. We're going to focus on how each professional on that team thinks and acts in those first critical moments.
Here's how we'll walk through it. We'll start with the emergency itself. Then we'll look at the physician's diagnosis, what the nurse is watching for, how the therapists provide hands-on support, and finally, that really tough decision, knowing when it's time to make the call to escalate care.
Okay, so it all kicks off with one really frightening symptom, acute breathlessness, or what we call dyspnea. For the team on the ground, the clock starts ticking the second this happens. They have to act fast.
The very first challenge is figuring out the why. Is this a heart problem, a lung problem, or something else entirely? Getting this right from the get-go is absolutely crucial because it decides everything that's going to happen next.
All right, so the physician steps in first. You can think of them as the lead detective on the case. Their job is to piece together all the clues, from the patient's history to their current symptoms, to figure out what's likely going on and get a treatment plan started.
So how do they do that? Well, they're looking for two very different sets of clues. If they suspect a COPD flare-up, they're looking for those classic signs like changes in sputum. But if they're thinking it's acute heart failure, the signs are totally different. We're talking swelling in the legs, a vein in the neck that's visibly raised, and crackles in the lungs. It's like following two completely different roadmaps to find the right answer.
And that initial diagnosis immediately dictates the first line of attack. If it looks like COPD, they'll start with bronchodilators to open up the airways. But if all signs point to heart failure, they'll use diuretics to help get rid of that excess fluid. This is all about targeted, evidence-based care delivered right there at the point of care.
Okay, so once that initial treatment is given, the spotlight really shifts to the nurse. They are on the front line, constantly watching the patient, monitoring their condition, and seeing exactly how they're responding to that initial treatment. And this is about so much more than just collecting numbers. Sure, you see the checklist here, they're tracking respiratory rate, oxygen levels, all of that. But they're interpreting trends. Is the patient working harder to breathe? Is the treatment actually working? They're also quantifying how breathless the patient feels. And, so importantly, they are constantly screening for signs of infection and sepsis, which is a huge safety net to catch things if they start going downhill fast.
Next up, let's talk about the therapists, both respiratory and physiotherapists. Their job is to provide that direct, hands-on support to literally help the patient breathe easier in that moment.
Now, this is a really critical point about oxygen therapy. It's not a one-size-fits-all treatment. As you can see, for most acutely ill patients, you're aiming for that 94 to 98% oxygen saturation range. But, and this is a big but, for someone with, say, severe COPD, too much oxygen can actually be dangerous. It can suppress their natural drive to breathe. So for them, the target is carefully set lower at 88 to 92%. Getting this right is absolutely non-negotiable for patient safety.
And it's not just about oxygen. The therapists have a whole toolkit of practical techniques. They'll coach the patient on breathing control, help them find the best position to sit in to make breathing easier, assist with clearing their airways if needed, and also help manage the incredible anxiety that, let's be honest, almost always comes with the inability to catch your breath.
But here's the thing. The entire team has to be ready for a crucial turning point. The moment when home care just isn't enough anymore and they have to make the call to escalate.
Because even with the very best team and the best care possible, a patient's condition can still get worse. And this is that moment where the decision to stay at home or get to a hospital becomes absolutely critical for their survival.
So how do they make that call? Well, it's not based on a gut feeling. The team doesn't guess. They rely on a very specific, evidence-based set of clinical red flags that act as a clear signal. It's time to escalate now.
And here they are. These are the hard stops, the absolute non-negotiables. If the patient's oxygen levels keep dropping despite everything the team is doing, if their skin starts to look bluish, if they're so exhausted they can't even speak in full sentences, that's it. Same goes for any new confusion or if their blood pressure tanks. Any one of these signs means the patient has crossed a line and they need to be in a hospital, period.
So when you look at the whole process, from that first frightening symptom to that final critical call, it's really a masterclass in collaboration.
Every single step is guided by clear evidence and amazing teamwork, all with one ultimate goal in mind: patient safety.
And that leaves us with a pretty big question to think about. As our population gets older and more complex medical care moves out of the hospital and into the home, how vital are teams like this going to be? It really feels like this highly coordinated model of care isn't just best practice, it's the future. Thanks for joining me for this explainer.